going to see types of primary headache. This includes migraine, cluster headache, and tension headache. So in tension headache, this is the most common of all the headache. Is just the headache that every person has when there is a lot of tension. Could be related to psychosocial stress. The patient is very stressed. The diagnosis criteria is more of two of the following. The localization is fronto-occipital. There is bilateral, bilaterally, with moderate to severe, let's say moderate intensity. It is not associated with or increased with physical activity as opposed to migraine. And the patient has this headache is like pressure or tightness. This is the characteristic of the headache. In tension headache, it could be episodic or chronic. If it is episodic, it lasts less than 180 days per year. That is less than half of the year, or less than 15 days per month. The same. And here would be more than 15 days per month, or more than 180 days per year. Now, it is very important in whatever headache we're talking about. We need to ask everything about the headache. When does it started? At which age it started? What are the triggers? What increases it? What decreases it? Or how it can be abortive? It is recurrent. It is primary headache. Which symptoms are associated, etc. And if there is a family history, the frequency, the intensity, the characteristics of the headache. And when we are talking about frequency, we are talking about how many days of headache, because the patient has 3 or 4 episodes of headache in the same day, but we want to know how many days of headache. So we want to see if it is less than 15 days per month or less than 180 days per year. But for that is very important to ask how many days of headache, not how many episodes of headache. Alright. For tension headache, in a sense it is a diagnosis of exclusion, because we will see that it is not migraine nor cluster headache. And the treatment would be, for abortive, is usually NSAIDs. And for prophylaxis, is tricyclic antidepressive drugs like amitriptyline, duloxetine, etc. Like 10 to 75 micrograms per day. So this was for tension headache. Now for cluster headache is part of the trigeminal autonomic headaches. The reason for which it belongs to the trigeminal autonomic headaches is because it is unilateral. Remember that it is, if it crosses to the other side, it is not due to the trigeminus. It's unilateral, is associated with, for example, Horner syndrome, meiosis, hemianhidrosis, and partial ptosis. Also, the patient can have rhinorrhea, conjunctival injection, and the pain is periorbital pain, and it is very, very, very severe. Could be the worst pain that the patient had. This is also the characteristic of the trigeminal autonomic headaches. This is unilateral, periorbital, with some autonomic symptoms like rhinorrhea, conjunctival injection, rubor of the head, meiosis, etc. And the most common of the ones is the cluster headache. It is seen more often in men, like 25 to 40 years of age. If it is the primary headache, yes, we will do an MRI, for example, to rule out other things. But if it's a headache of repetition, there is no need to do imaging again. And the characteristic of this headache is also that it occurs every time at the same time. For example, every time at the 8 of the night, something like that. It's usually seasonally related, so it would be, for example, on the winter, and then it can pass a year and then will return. Also, the patient could be awakened by this headache due to the extreme pain. And the cluster headache, the patient is very agitated, is very disturbed, as opposed to migraine. Here the patient is down and wants to rest, wants to be on a quiet room. Here the patient goes to the emergency department or something like that, because the patient is on extreme pain and is very very scared. The treatment would be 100% oxygen, 7 liters per minute for 15 to 20 minutes, or we can give sumatriptan or some triptan, but we prefer to give the oxygen. And for prophylaxis, we can give valproic acid, verapamil. We prefer to give verapamil, certainly this is the most effective, and verapamil is a calcium channel blocker. Lithium. Remember that the concentration of lithium needs to be between 0.5 and 1 microgram per liter. Or prednisone. Prednisone could be in conjunction with verapamil or lithium, or just alone. Also, we can give ergotamine sometimes if these sumatriptans are contraindicated, but this would be more for prophylaxis. And antagonist of the gene-related protein peptide. The same as for migraine. Here the difference would be that in migraine the patient is down, wants to be in a quiet room, and in the cluster headache, yes, we have this trigeminal autonomical headache, but the patient is very scared. Here the patient presents with migraine, usually unilateral, pulsating. It is increased with physical activity. This is not that it is increased when the patient is going to pick something, because this would be increase in intracranial pressure. This would be a secondary headache, and this is a alarm symptom. We mean that as the day goes by, the headache increases. Also, we need vomiting or nausea, the two of them, and photophobia or phonophobia. There are some things that can precipitate migraine, like foods, like chocolate, wine, cheese, bananas, etc. And the patient can have migraine with aura or migraine without aura. Aura is when the patient perceives something before, like could be numbness of the extremity, could be loss of vision, could be a bad odor or something like that. When the odor of something increases the pain, it is called odorophobia. So it could be called migraine with aura, or could be migraine without aura. Very common aura could be the patient sees these scintillating scotomas. This scintillating scotomas is not that the patient lost the central vision or that you see like black. No, here it is that the patient sees this central vision as moving a little bit, like just animating this central vision. Well, really it is not understandable if we think about it. Certainly we will need to see how the patient is seeing. We cannot just talk about that. So this would be migraine. This is due to vasodilation and vasoconstriction of the blood vessels. There is also inflammation of the meninges, and so the treatment is antagonist of the 5-hydroxytryptamine 1BD, These are the receptors of serotonin that are involved on this headache mediator. So if we give these antagonists that are the triptans, we will stop it. So could be sumatriptan, for example, and the route of administration depends on the severity of the headache. The abortive is usually triptans or ergotamine in the case that the patient has contraindication to triptans. The contraindication would include pregnancy or hypertension. Ergotamine does not produce hypertension. Sometimes NSAIDs, not very common. And for abortive, we could give topiramate, tricyclic antidepressive drugs, metoclopramide. This is not first line because can increase the extrapyramidal symptoms, and in this case we will give metoclopramide plus some anticholinergic medication. Beta blockers. Beta blockers can be given in a pregnant woman, but to the lower dose that the patient requires, because this can lead to growth restriction of the baby. And certainly the antagonist of the gene-related peptide, calcitonin. Actually, it is calcitonin gene-related peptide. So the prophylaxis for migraine and cluster headache could be very similar, but we need to distinguish these. And there's something called overdose headache, that is when the patient usually has a chronic headache and takes daily medications, usually NSAIDs, and then the headache, the same headache, could be migraine, if this was the underlying headache of the patient, increases the severity, and there are less free intervals. And this is due to a rebound effect of the overdose medication, and so the treatment is just suspend the medication for a while.